Welcome back to the MedTech Snapshot, the one question, one answer, highly digest medical device podcast. Through these next 3 episodes that you'll be watching, Brad Maruca, Managing Director of Deloitte's MedTech Division, shares with us some really interesting topics having to do first and foremost with our OEMs and industry partners potentially making the wrong decision and strategy as it relates to how they focus on building their organizations and looking first at addressable markets and clinical outcomes. We also dovetail into episode number 2 on looking at bias and data bias, and for the fact that at the very end of the year, patient procedures and demand seems to uptick every single year. And why are we not talking about that a little bit more within the industry to build better strategies? And last but not least, Brad seems to be able to weave in an interesting story having to do with the bull weevil in his career. So stay tuned. Welcome back to MedTech Snapshot. With me today is Brad Maruca. I'm really excited to dive into this detail, but first, Brad, why don't we have you introduce yourself?
Sure. Travis, thanks for having me on. My name is Brad Maruca. I'm a managing director at Deloitte. Been here coming up on 4 years, August. Prior to that, I was in MedTech, so 26 years in MedTech. I spent 19 of those years in neuromodulation.
All right, Brad, so as we kind of dovetail into our second topic here, I really love this part because I never hear people talk about it. And then when you and I had been talking privately on this subject, the example you gave me hit home. My wife and I just last year had bought a new car, and then all of a sudden, we're driving around. I had never seen this car before, but now magically the car's all over the freeway. I'm seeing it everywhere. So it's this idea of bringing it back now into industry. There's something that all OEMs know about, they just don't talk about, which is the fact that at the end of the year, procedures from a demand perspective seem to have a pretty big uptick. So I'd love for you to kind of explore with me, why is that the case? But perhaps just as important, why aren't we talking about that more in industry?
Yeah, Travis, it's so fascinating. You're talking about that familiarity, that pattern recognition that you get once you find yourself intellectually or emotionally attached to something. You start to see it everywhere. So I'll just apologize in advance that now this is something that all of your listeners will probably be thinking about, but this has been hidden in plain sight for years, right? Yeah. The phenomenon is real and well documented, and it's driven by deductible exhaustion. So in the US, most commercial plans reset January 1st. So by October to December, a meaningful portion of these insured patients with employee-sponsored plans have kind of met their annual deductible and out-of-pocket maximum. So at that point, elective or deferrable procedures, which I'll caveat, is 90+% of MedTech product. I think I commented to you, Travis, during that first discussion that my dad had a minimally invasive CABG procedure. This is a bypass. He shopped the bypass, okay? So everything, even the things you think are emergent and not elective are often elective. But the point is that those elective or deferred procedures effectively become free to the patient from a marginal cost perspective at the end of the year because they've met those maximums. So we think about health economists know this already. They've documented this December spike in elective procedures. So orthopedic, spine, ophthalmology, GI, all show Q4 volume lifts and claims data. This is like an advisory board, definitive healthcare. This is all published for procedures with significant cost sharing. So think about let's just say you get a lumbar fusion, a very, very common procedure. You have $3,500 out of pocket for a $40,000 lumbar fusion. So the difference between a September procedure and a December procedure can be an entire patient cost, which is a powerful behavioral driver. So this is why I like to bring behavioral science into this equation. And so you figure, 55% of plans now are these deductible maximums. So this is a big portion. So what do the OEMs know but don't act about, right, Travis? This is the kind of thing, so I bring this up. Everybody knows there's a spike in procedure volume, not just sales at the end of the year. We then attribute it to seasonality, which we know is a copay maximum, but we don't operationalize it, right? We're organized around the rep activity. So call frequency, procedure support, rather than patient demand elasticity, right? And so basically we've been building on the demand side through patient awareness and pathway navigation, but we never made provision in the way that we commercialize based on this patient out of pocket. But you know who has? Pharma, right? It is near ubiquitous in pharma that they have copay coupons to offset the patient out of pocket. So they know this to be true. They harness it. but MedTech has never operationalized the concept of patient support services. They do it for somebody who may be destitute, right? But that's a sliver of the patient population that's really affected by these. So I think we need to reframe the conversation into kind of these Q3. What should the reps be doing? They should be planting seeds with surgeons in the summer. So we talked a little bit about summer vacations with physicians. It's a good time to plan. What they ought to be doing is creating demand, planting seeds. Talk about your Q4 volume plan as a physician. Which patients are on your watch list? Should we be thinking about together? Are there any programs that we should be implementing on your behalf that'll help them reach that copay maximum and get the procedure that they deserve and need and they find medical necessity to do so? I mean, what gets the most fanfare are diseases like cancer, where we know the time factor is critical to the outcome, but it's just as critical in terms of outcomes in all these other areas. And so this idea is not just about, can I get patients to move forward so they don't have this loss of therapeutic momentum, I'll call it, when they're identified as a candidate and ultimately get the procedure, but how do we get them the procedure at the time that is recommended so they get the best possible outcome? So this again is not pure altruism, but it is a problem that we have, which is not market access, it's patient acceptance. And that's the real gap I see. So I think that we need to change the way we orient ourselves towards the patients and the way our reps are oriented in the summertime, in this lull, towards their physicians. What's our Q4 plan? Who's on the wait list? What provision are we making? Are we maintaining contact with them? Do we have available capacity to do these procedures? And is there any way that the industry or the manufacturers can help us offset some of that out of pocket so patients can get the procedures that they need? So
within this discussion,
before I die, Travis, I want to innovate the copay coupon for MedTech.
If we take this downstream a little further with a commercialized organization, the thing that I also think about is, are we taking this idea and this strategy and are we planning for it from an inventory perspective?
Yes.
And then how often do we find that our OEM partners are scrambling last minute to be able to keep up with a volume that if they had paid more attention from years prior, they knew was coming. Yeah. So now we're reducing freight charges, stocking charges, right? So there's all these extra charges that get spooled up when we need to move quickly because we weren't forecasting properly. Any thoughts on that?
It is a great point, Travis. I guess I would say that in a lot of cases, they're not resource constrained. And this is why I made the distinction at the end of year between sales and procedure demand. Because let's just say that you're on a calendar fiscal. It's very common for our MedTech industry partners to do quantity purchases, give a 10% off if they buy 10 in advance. But this is the exact juxtaposition of where they should be investing. So rather than 10% off on a device on December 31st to get them to stock and reach their number, that then is going to sit on the shelf because the copays have reset January 1st. So think about how ironic that is. I end up selling the devices at a 10% discount year end to get a quantity purchase. Those sit on a shelf, so we get shelf pressure. But then we don't end up regenerating patient procedure demand because the copays have been reset January 1st. So now we're chasing this number all year long. We're trying to burn down the QPs. Now we're trying to get demand back on track. You see the cycle we're trying to break? So the ideal scenario for me would be, let's take that 10% discount dollarized and use that to offset the patients out of pocket in that quarter. Now we're selling our devices at full price, right? And we're putting the investment we would have made to the facility in the patients. The facilities are still getting the money. They're getting it paid directly by the industry, not through a discount, but through a copay payment. So we're still paying the facility as an industry partner. We're just not paying it in a discount that doesn't benefit the patient, who, by the way, has the elasticity and demand.